Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z
and John. Well, good morning, Zara.
Hi, John.
We've got Dr. Paulo Hoff, who is the Professor of Oncology at the University of São Paulo, Brazil. And I just want to refer all the listeners back to his first episode on rectal cancer, which gives you great insights into the disease, the treatment pathway that a patient would take, and then also he's leaving comments on what you should be looking out for. Please go back to his first episode. This episode, we have Paulo talking about colon cancer, which is significantly on the rise. They're predicting that there will be over 2 million people newly diagnosed every year. By 2045, over 3 million people diagnosed with colon cancer, and it's happening in younger patients, similar to what we discussed with rectal cancer. So, Paulo, can you just introduce yourselves to the listeners on this episode? Talk a little bit about your history at MD Anderson and all the research that you're doing both in the United States and now in Brazil, and that amazing hospitals that you've got down in Brazil and the work that you're doing there.
Hi, John and Sarah. It's a pleasure being with you again. As you said, I'm professor of medical oncology at the University of São Paulo, and also here in Brazil, we tend to have a second job and president of Oncologiador, which is a network of cancer centers. And we continue doing a lot of research. My special interest since I was at MD Anderson has been the development of new treatments for colorectal cancer. And always a pleasure to be able to talk about that, especially with friends.
Thank you.
This session is specifically going to be focused in on immunotherapy in colorectal cancer, but you've got the earlier diagnosis before we get to the use of immunotherapy, and maybe then in early stage and late stage disease, how you use immunotherapy.
Sure. Colorectal cancer, as you mentioned, is not only a common cancer, but its incidence worldwide is on the rise, and it's becoming a major health problem. Even though we are able to cure a lot of those patients, even luckily the small numbers that are not curable become a huge number of patients because of the size of the patient population. So once you make the diagnosis, you go to a staging process where you determine if the tumors are localized or have spread to lymph nodes, which are agglomerates of defense cells that we have throughout our bodies and tend to be the first place that tumors invade if they start spreading from the original location, or if the patient has distant metastases. And that will pretty much determine how we treat the patients.
Similarly, when we discussed rectal cancer in our previous episode, there were symptoms that are associated to prompt a patient to go and seek out, their clinician. Are there certain symptoms that would also be that should prompt a patient to maybe go and then seek out medical treatment?
Yeah, excellent question. In fact, the symptoms are very, very similar to the tumors that arise in the rectum. Patients should be looking for presence of blood in the stools, difficulty evacuating, or unexplained weight loss. If the patients notice a bulge or a tumor in the abdomen, those are the things that could be seen. However, if you have a tumor that originated in the right side of the colon, our colon looks like a question mark, and you have a right side, a transverse colon, left colon, sigmoid, and then rectum. Tumors that arise in the beginning of the colon tend to be much less symptomatic because at that stage, our stools are still liquid. So the tumors have to grow a lot before they become symptomatic. Tumors that arise in the left side, they tend to become symptomatic earlier because the stools are already formed and you have more alterations in stool form, bowel habits, things like that. That's why it's so important after the age of 45 for everyone, and even younger than that for patients who have family history, to start screening, because our best chance to detect early colon cancer is through screening.
My sister had colon cancer. How is that approach today's world of colon cancer versus her world 20 years ago? Is there a significant change in the way we treat colon cancer?
Well, for people with localized disease, the changes have been minimal, I would say. So patients who have from stage 1 to 3 tumors that are localized, at most have involved lymph nodes, they are treated primarily with surgery. There's no need to do any treatment prior to that, although that's possible, usually it's not required. And the biggest advances that we saw in the last 10 years were regarding the use of laparoscopic surgery or robotic surgery, minimally invasive types of procedures, but the essence remains the same. For people with tumors up to stage 3, surgery tends to be the primary mode of treatment and should be applied as soon as possible. If the patients have metastases, then the algorithm changes a little bit, and sometimes we start with chemotherapy, sometimes we start with surgery. It will depend on symptoms, location, extent of metastatic disease. But that's the way we usually proceed. For early tumors, surgery usually the first treatment.
You mentioned left side versus right side, which is a whole different field now. There's different biomarkers that actually happen that cause you as the oncologist to treat them differently.
Sure. Now, important to mention that those changes will apply especially for patients with metastatic disease. For patients with early disease, it doesn't really matter if the tumor is in the left, transverse, or right colon, treatment will be surgical. However, for patients who have metastatic disease, the site where the tumor originated makes a huge difference. Tumors that arise in the right colon tend to have different types of molecular markers, mutations, compared to the patients who have tumors arising in the left side. And they tend to respond differently to several types of treatments that we use. So initial chemotherapy for patients with right or left side tumors will be different. The other important thing is that a small percentage of patients with colon cancer will have tumors associated to microsatellite instability, which is a condition associated with formation of tumors in roughly 15% of the cases of colon cancer. And those patients tend to have their tumors mostly in the right side as well. So important for us to make this distinction. And as you said, nowadays, the side where the tumor is started makes a big difference.
So, as part of the making the big difference, right versus left, would you say that the tumors could be more aggressive based on the sidedness of the colon?
Well, and of course, I think we should point to the audience that it's not necessarily the side, it's the mutations that are present in each side that make the difference. And yes, the tumor aggressiveness will be different in both sides because their molecular components are a little bit different. So they tend to progress at different rates sometimes, and they also tend to respond different to different types of treatments that we can apply towards them. It's almost nowadays, it's almost like you have different diseases within the same organ. And even in the same site, let's say a right-sided tumor that has microsatellite instability would be treated very different than a patient with right-sided tumor, but who has a tumor that is stable, that does not have those microsatellites present in their DNA.
So, I guess my leading question to that is, as a patient, I'm sitting in front of you. How do I enter, or how does this discussion happen? Do you say to the patient, okay, you've now been diagnosed with colorectal cancer, your stage 4, you're advanced, you've metastases. Do you walk them down like genomic testing? Is there a panel of biomarkers that they then would need to be subjected to? How does that conversation, like, what does that look like?
Well, actually, it's surprisingly similar to what you just mentioned, because Yes, we do talk to the patients and explain that nowadays colon cancer can be treated many different ways. Is that in that we're going to find exactly how their tumors will behave and will respond to different types of therapy. So there are certain molecular markers that we'll check on every patient. For example, NRAS, KRAS, BRAF, microsatellite instability. Those things became quite common, and of course would be different depending which part of the world you are. But most physicians who are interested in colorectal cancer will want to see those molecular markers tested in the tumor before they make a final treatment plan for the patient.
And the molecular testing, is it liquid biopsy or do they need the actual tissue from, how is that done?
Well, since a lot of those patients have had surgery, it's easy to get the primary tissue from the tumor that was removed. But if that's not available, yes, there is the possibility of you doing liquid biopsies. They are commercially available and they're quite good as well.
You bring up a good point there. I was just thinking back what happened with my sister. If she relapses, so touch wood, it's been 20 years now, so she's well past the 5 years that we discussed in the first episode of 5 years. Would the tumor markers be the same as the original, or would they potentially change? Would the disease have
Excellent question.
progressed to a different stage?
It has to do a little bit with the timing. Of course, the closer the tumor relapses, the more likely that they're the same. The chances of you having a different molecular profile is not zero, but it's small. Most of those changes, they are what we call driver mutations. They were associated with the formation of the tumor, so they tend to be present in the original tumor, and the cells that descend from that tumor tend to carry those mutations because they were important in the formation of the tumor. So again, most of the time, there will be a high level of coincidence between the markers seen in the primary tumor and in the metastasis, but it's not 100%.
Yeah. And just on the tumor markers, because in the clinical trials, when we're doing clinical trials, we always have a central repository for actually assessing the tumors. When we're doing the trial, everybody gets exactly the same panel and it's read by exactly the same process. In the real world, does that biomarker reading change from one hospital to another? Should there be a second opinion on the outcome? Do you understand what I'm asking?
I do. There's a high level of coincidence between different labs. However, again, it's not 100%. So it's not uncommon for us to do a second opinion on the pathology, especially if the pathology doesn't give the results that we like to see. So sometimes you try again. And sometimes you even do a new biopsy if you feel that there was a problem with collection or the preservation of the material. So there are many, many variables in there. There's not an easy answer to that. In an ideal world, we will have perfect testing all the time. In real world, there are many variables that might affect the result, of course.
Okay.
So now we move more like into the treatment, I'm going to say algorithm, because I believe that, colorectal cancer treatment is similar to breast cancer, where you have a significant number of options, therapies that are available to that patient. So maybe Dr. Hoff, John and I both have history in working within the colorectal space, so we've been blessed. But, as audiences and listeners are going through this episode, maybe walk us through, okay, these are your treatment options. This is what the treatment algorithm looks like, so that, in turn, patients are better informed and can have that conversation with their healthcare professional if time comes.
We might need another episode for that. So many variables. I mean,
We'll take it.
nowadays, there is a basic premise for chemotherapy. 5-FU, which was developed more than 50 years ago, remains the backbone of treatment for metastatic colorectal cancer. but you add things to this backbone, then there are two other chemotherapy agents, irinotecan and oxaliplatin, which are very important, and they can be added to 5-FU, either one of them or even both of them. The more drugs you put on, the greater the response rate, but also greater the toxicity. So your physician, the physician that's dealing with the case, will decide what's the best combination. Once you decided on your chemotherapy part,
Got
you're going to decide what kind of molecular agents, targeted agents you're going to use. And we have two big families. We have the anti-EGFR and the anti-VEGF antibodies that can be added. As a general rule, most of the time, if the tumors arise in the right side, you're going to go with anti-VEGF because the anti-EGFR, for reasons that are not completely understood, do not work as well for tumors that have a reason in the right side, more effective for the tumors that arise in the left side. And in the left side, you have the option of using anti-EGFR or anti-VEGF. A lot of people like the anti-EGFR because they feel that the response rate would be a little bit higher. But the reality is that all those options are very similar in the outcome, and the expertise of the physician, seeing the case, examining the patient, looking at the alternatives will help to decide which is the best approach for that particular patient. So could be 1, 2, or 3 chemotherapy agents, usually with one monoclonal antibody added. And this would depend on the location of the original tumor and what you plan to do for the patient later on. If it's a treatment that will be a maintenance treatment, or if you're trying to turn this patient into an operable case, all this will influence what treatment type you offer the patient.
So today's topic is on immunotherapy and colorectal cancer and the colon. How does that play into the 5-FU, the EGFRs, the VGFs combinations? Where do you place it? Do you place this in the neoadjuvant, adjuvant side, or do you place it in both the adjuvant and the metastatic side? And what's the results that you would expect from immunotherapy in this field?
So immunotherapy has been a very promising new mode of treatment for different types of tumors, and it's the same for colon cancer. However, for colorectal cancer, we do know what is the population that is more likely to benefit from immunotherapy. Those are the patients with microsatellite instability or very high tumor mutation burden. And I mention that because it's not very common, but there are other mutations. For example, patients who have a tumor associated with mutation, the POL1 gene, they tend to have a lot of mutations. So they form a lot of neoantigens, and they tend to have a great response to immunotherapy. What do we know about immunotherapy for those patients? So one, it's a treatment for those patients who have very high tumor mutation burden or microsatellite instability. Two, there are no trials that have shown benefit of using immunotherapy in the adjuvant setting. So once you have removed the tumor, we don't have any evidence so far that could come up in the future, but so far we have no evidence that using immunotherapy after that will bring any added benefit. Now, something very interesting, slowly developing, the response rate for those patients with metastasis is high, and the survival curves are excellent. Those patients tend to live a long time. However, when you use, as you mentioned, as neoadjuvant, before the removal of the primary tumor, the response rate seems to be even higher. So there's great interest now in trying to move immunotherapy to be investigated in earlier stages of the colon cancer. Only patients have those particular characteristics that will make them high responders.
A lot of advertising in the United States about immunotherapy, about a lot of different immunotherapies, and there's even now some discussion on other tumors with ADCs. I'd like for our patients to specifically know, when they go to their doctor, what is the discussion about immunotherapy that they should be asking?
I think, they should ask their physicians, am I a good candidate for immunotherapy? And if they are, I'm sure the physicians will want to give them because the results are really good, and we want to be able to offer that to the patient. So if you go to your regular oncologist, I would ask, am I a good candidate? And go from there, because that's well established. Now, if they go to a place like MD Anderson or Mayo Clinic, places where you have Memorial Sloan Kettering, where you have a lot of research, you might ask also, well, if I'm not a good candidate for immunotherapy that's being applied now, am I a candidate to something experimental that's trying to breach that void and make tumors that are not responsive to immunotherapy to become responsive? Because there's a lot of things in that area being investigated. But of course, it's experimental. We don't know if it's going to work. But those who are interested in immunotherapy could also try that approach.
Because my mind always works around kind of numbers as well. You'd mentioned in terms of neoadjuvant bringing in immunotherapy earlier, and you're seeing great response rates. What are those numbers looking like? What were we at benchmark, and then what is now being established in terms of responses in the neoadjuvant?
Well, we rarely did neoadjuvant chemotherapy for colon cancer, but we know that the complete response rate will be probably in single digits. There are no reports of consistent complete responses using chemotherapy for localized colon cancer. Although I'm sure there would be one or other case that in which that would happen, certainly would not be the norm. Now, the numbers are very small for immunotherapy, but as we saw with rectal cancer, where some reports go as high as 100% of complete response, in colon cancer, the numbers are very, very high, getting close to that. So, do I think that 100% of patients will have complete responses in clinical practice? Probably not. There's always a different outcome when you're using something in real life.
Right.
There are different things that will influence the outcome. But it's so high that even if you give a discount, it's probably still going to be very, very high, and will tempt us to start doing, perhaps in the future, think about watch and wait, not only for some certain cases of rectal cancer, but even for colon cancer. Perhaps it may become an option in the future.
Okay.
Can you explain what watch and wait is, Paulo? Because it's a term that we use all the time, but it's not a term I don't think that the doctors discuss a lot with patients, what watch and wait really means.
Yeah. It's a different concept, because you can say, I'm going to treat you and I will include surgery, or I can say, I'm going to treat you and going to observe if you need surgery in the future. So you watch and wait to see if the local treatment, be surgery or in certain cases radiation therapy, would be necessary. But you're already saying, when you say watch and wait, that you're not ruling out the use of a local treatment. It might be necessary to operate. It might be necessary to do radiation. But saying that, it's in certain instances very useful, especially when the local treatment would impart in some type of a definitive change in the body of the patient. For example, removing the rectum.
Thank you.
I mean, to your point, I think that it would be great for us to get further into some of the treatments for metastatic colorectal cancer. But if you could just briefly kind of talk about, again, with regards to outcomes or numbers, just briefly, and then maybe give your top 3 takeaways. But what numbers are we looking at in terms of patient survival? We said, the curves are really extending out, but what are we looking at in terms of survival benefits for patients in the metastatic stage?
Maybe, Paulo, can you just start like the survival 5 years at 2000 when we were doing our studies?
Well,
What the survival was then versus what the survival is now.
I can go further back in time.
Yeah, I know you can go further back, but I can't.
When we did not have any formal treatment for metastatic colorectal cancer, the life expectancy was around 6 months to 1 year. When we began using 5-FU alone, or leucovorin, which is not necessarily a chemotherapy, our life expectancy went up to about a year. Now, with everything that has been added since 2000, we over 35 months of median overall survival. And the very important thing for the audience, we're not saying that you're going to live 35 months or 36 months. That's median. Some people are doing way better than that. We have patients who are a decade being treated for colorectal cancer in their life. And that's important because people tend to concentrate in the numbers if we give them numbers. And what we're saying is that life expectancy has gone up a lot. Now, to give some idea on the benefit of immunotherapy, for example, let's remember that immunotherapy now has been investigated not as the first treatment, but after you have already failed chemotherapy. In instances where the median overall survival was about 4 months, and again, that's not what the patient lived, that was just the median. The overall survival with immunotherapy goes beyond 2 years. So it's way. Now, once we move this to patients who have tumors that have been less treated, the expectation is this is going to get even better. Now, again, there's a difference in when you're conducting studies and real life, but the reality is that the differences are so big that probably we're going to see huge impacts later on. That's what we expect, although still remains to be proven, of course.
And of course, you're involved in those studies. So are you seeing a trend? Are you seeing this sort of trend from your own research that you're doing at your hospital in Brazil?
When we treat patients who are adequate candidates, the responses are very, very encouraging. And that's also very important. Unfortunately, it's not a treatment for everyone. And it will be counterproductive to give this to every patient. It has to be given to those patients who really will benefit, not only because of the cost, but also for those patients who will not benefit. You should be trying to find something else that will help them, right?
Right. So I know that we've taken a lot of your time. So I just want to be respectful of that and maybe share with us like top 3 key takeaways from your perspective with this topic that we've been discussing of immunotherapies specifically for colon cancer.
Okay, for colon cancer, I think the first one is that you should be doing your screening. It could be at 45 years of age or even earlier if you have family history. The second thing is that when you discuss with your physicians, you should be asking if you're looking into the molecular makeup of the tumor, because that will help to find the best treatment for you. And finally, I think that people should be open-minded about joining clinical trials because there's so much going on. We need volunteers, not only to be able to benefit early from the new treatments, but also to help shape better treatments for the future. So we need greater participation in clinical trials. That's very important.
I think that's a really great, very, very good point. Thank you.
And what are you doing in your hospital, just to let listeners know the work that you're doing at DOOR?
Right now we're working a lot trying to enter as many patients as possible in trials that are exploring immunotherapy, either in situations where it's well established or, like I said, entering trials where exploring different ways of making patients who are not candidates to become good candidates. I think that's the trend worldwide, John. I think everybody's pretty much looking at the same goal right now, trying to bring this to as many patients as possible.
Well, we thank you for all the research that you've done for patients for many, many years, and you've definitely changed the survival curve in colorectal cancer dramatically. And I can't thank you enough for all that. That you've been an amazing doctor to work with and a researcher as well. And we want to, on behalf of MedInsights Unleashed, I just really want to thank you sincerely for everything, for these 2 episodes that you've done, and maybe a third coming along at some stage or other. And we'd love to have Anna on to talk about thyroid if that's possible. I know that you've got a good in with Anna. So that would be nice.
Meet you and Sarah.
Thank you. Thanks, Dr. Hoff. It was lovely meeting you. Thanks again for our great discussions.
Thanks, Paula. Bye-bye. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.